네, 안녕하세요.
Hello, I'm Chung Jae-eun from Seoul National University Gwanak Dental Hospital. Today, we'll look at a retreatment case for number 46 peri implantitis. I took a surgical approach for this case and performed regenerative surgery along with bone grafting. Let's take a quick look at the patient info. The patient is a 64-year-old female. The probing pocket depth for the number 46 implant was 6 to 8 millimeters, and pus and bleeding were also detected. This is the implant I placed back in 2017. After diagnosing it as number 46 peri implantitis, I decided to proceed with treatment. On the panoramic X-ray, you can see bone loss around the number 46 implant, extending to about 1/3 of the implant. On the periapical X-ray, bone loss is even more prominent. From X-rays, you can get a rough sense of the defect type. I expected this to be a two-wall bone defect, with only mesial and distal walls remaining without the buccal and lingual walls. For various reasons, you get to decide on an appropriate approach to treat peri-implantitis. These criteria here are not noted in textbooks, but I listed them based on my experience. The extent of peri-implantitis, implant position, patient cooperation, defect type, the quality and quantity of soft tissue, cost, and the overall treatment plan. For a defect like this, it's not actually ideal for regeneration and bone grafting, since a 4-wall, or at least a 3-wall defect can guarantee decent bone grafting results. To give you some context, this person has long been a patient of mine, and I did place the implant. The patient was also very cooperative and had enough peri-implant soft tissue. In terms of cost as well, the patient was willing to invest, so I decided to proceed with regeneration surgery. I first performed scaling and root planing for number 46. Since removing the number 46 crown beforehand makes the surgery much easier, I plan to perform flap surgery after removing the crown, and proceed with bone grafting if possible. After watching the surgery, we'll look at the causes of this patient's peri-implantitis. One of the most important factors is the quality and quantity of soft tissue. Others, such as the interface between the implant and the crown, and the frequency and routine of follow-up visits, are also to blame. I'll review them later. Now, let's take a look at the surgery video.
다물고 한 2, 3분만 있을게요. 아예 약좀 남았거든요.
What do you think? Before going into details, let me first explain what the situation was like when the implant was placed. This patient came back for a follow-up after a long time, and I was quite surprised to detect peri-implantitis. So I looked over the previous charts, which showed that the implant was placed in 2017. The surgery was a one-stage procedure with a flapless approach. This means that both the bone and soft tissue were decent back then. The implant was Osstem's TS system, with a diameter of 5 mm and a length of 10 mm. And here I left a note that the gingival thickness was about 1.5 to 2 mm. The CT scan also shows very thin soft tissue. I placed a 6 mm diameter, 3 mm length healing abutment. In usual cases, an abutment with a length of 4 or 5 mm is used instead of a 3 mm one. This also means that the patient had very thin gingiva, but the implant was placed rather at a shallow depth. I actually brought some CT scans and charts from back then to highlight this point. Let me emphasize the basics here. The peri-implant gingival thickness affects peri-implant bone stability. Many lectures and seminars talk about this. so I'm sure you are all familiar with it. In the famous Berglund experiment, there are two groups with a gingival thickness of 4 millimeters and 2 millimeters. Then, what happens to the 2 millimeters group? It's not going to remain intact. Instead, the bone will resorb to secure a thickness of 4 millimeters. These are histological photos. You can see that the bone resorbs to secure a thicker gingival layer. I always mention this during lectures, but it can be overlooked in practice. Some may not place the implant deep enough for a patient with thin gingiva or skip the soft tissue augmentation. This photo shows a patient in a similar condition. It's not the case we're discussing today, though. I collect these similar cases and keep them in mind so that I don't make the same mistake again. Like the patient in today's case, this patient also has a very short healing abutment, and the gingiva is really thin. This is the photo after prosthesis delivery, but for a case with really thin gingiva, if the implant is not placed deep enough, the interface between the implant and prosthesis gets really close to the marginal bone. Then, leakage here can result in bone loss like this. In just a year, it had become like this. For this patient, about 7 or 8 years have passed since the placement. I opened a flap and did a bone graft, but looking back, I think I should have placed the implant deeper. That was the wrong start. What contributed to the development of peri-implantitis in today's patient? I mentioned the soft tissue thickness as one of the causes. Secondly, well, I have actually been following up on this patient, but I didn't take periapical x-rays at every visit. This is the periapical x-ray from 2017 when the implant was placed, and these are at 1 year and at 2 years. I had been properly following up on this patient, but then 4 years later, I only took a panorama. I hadn't felt anything off back then. And again, another panorama was taken at 5 years. Then in 2023 and 2024, I didn't take any x-rays. And when the patient recently came back, I noticed that the bone loss had progressed quite a bit. Textbooks say that we need to take periapical x-rays every year after implant surgery. That really does mean something, since they can be very important data to detect the early signs of peri-implantitis. So, I want you all to take periapical x-rays once a year. It's too bad that I hadn't been stricter in following up on this patient and took action too late. This is another patient. From the time of implant placement to crown delivery, 3 months later and 1 year later, you can see the development of bone loss. Usually, it is a 3-wall or 4-wall defect, and the bone grafting results are also very good. So for implant placement cases, I once again emphasize the importance of regularly taking periapical x-rays for follow-up. Let's go over today's case again. I opened a flap, and there was a circumferential defect. The pattern of peri-implant bone loss is mostly like this. In the very early stage, it is usually a 4-wall defect. As it progresses, the top region shows horizontal bone loss, while the bottom becomes a 2-wall defect. That's why early diagnosis and treatment are crucial. Here you can see that the area around the implant looks a bit rough and grayish, or rather black. What matters before bone grafting is how clean you can make the implant surface. So I usually spend most of the time in regeneration surgery on debriding the implant surface. There is no specific tool for this, but I usually use a scaler, specifically the metal tip of an ultrasonic scaler. Then I wipe it off several times with a cotton pellet soaked in chlorhexidine or saline. Along with mechanical debridement, I also used a special burr for this case. After that, I performed bone grafting using bovine bone and a collagen membrane, and finished by submerging the implant. I didn't perform much of a vertical releasing incision for the flap. Since I just closed it and the soft tissue is really thin, it might open up a bit. This is the X-ray taken after the peri-implantitis surgery. In the photo, you can see the defect is filled in well with the grafted material. But I need to keep an eye on how long it will maintain this state. Since it's a two-wall defect, it is expected to subside to some extent. Here is the photo taken at suture removal, 2 weeks after the surgery. There was some dehiscence. So I decided to connect either the implant prosthesis or a healing abutment. Since I just closed it without performing much releasing, I expected a soft tissue defect. I first connected the healing abutment, and later I will connect the prosthesis. The regenerated region is healing well without any signs of infection, but I need to see how much the bone grafted area will maintain. Today we looked at a regeneration surgery case for a number 46 implant defect. I hope this helps you in your clinical practice when dealing with peri-implantitis cases. Thank you for watching.